So I will be speaking about the performance of CLADs in heart failure patients. Now, when we as anesthesiologists deal with heart failure patients, what things come into our mind first? What are the major anesthetic concerns for heart failure patients? Now, not necessarily all heart failure patients will have depressed cardiac functions, though previously it was often thought that patient with heart failure has depressed cardiac function, but nowadays there are lots of classification of heart failure with preserved ejection fraction, heart failure with improved ejection fraction, minimally reduced ejection fraction, and heart failure with reduced ejection fraction. So patient with a normal ejection fraction can also have heart failure, but the thing in which we are more concerned is the patients in which the patients are having heart failure with reduced ejection fraction, because the patient coming with reduced ejection fraction increases the anxiety as an anesthesiologist. So especially the patients who are having decompensated heart failure have hemodynamics maintained on high levels of circulating catecholamines, and when we anesthetize the patient, and as soon as the patient goes to the sleep, his circulating catecholamine levels drop because of the sleep we induce. So that can lead to a sudden catastrophic drop in the hemodynamics. And also in heart failure patients, the pharmacokinetics as well as the pharmacodynamics of the anesthetic drugs are altered because of altered volume of distribution, as well as due to reduced clearance of the anesthetic drugs due to reduced cardiac outputs, and also in low cardiac output states, as the vital organs are luxurially perfused like the brain and the heart. So not only for achieving the desired effect site concentration of brain, the dose of anesthetic agents needed is less than that of a normal patient, and also the rate of infusing that anesthetic agents is also required is less to achieve the required target effect site concentration. So all these things has to be kept in mind when anesthetizing in a patient with heart failure. And also due to intraoperative hemodynamic fluctuation, as well as for preemptively for avoiding the hemodynamic fluctuations, often unknowingly we administered very less or little anesthesia during the phases of hemodynamic perturbations. Yeah. So the patients also have a high incidence of intraoperative awareness. So what are the anesthetic goals in patients who are having heart failure? So carefully titrated induction to avoid catastrophic hemodynamic collapse and major hemodynamic fluctuations, and also maintenance of adequate depth of anesthesia while avoiding hemodynamic instability. Now, how does CLADS address all of these? So we have a mode of high risk and very high risk mode in CLADS. So whenever we choose that option, it basically reduces the initial rate of propofol infusion. In normal patients, at which rate CLAD starts to give the infusion, that initial rate of propofol infusion is reduced in high risk and very high risk patients. Also, the initial target concentration of propofol which is targeted is reduced in these patients, and also the time period to achieve the target concentration is increased by default in CLADS, and also the increment in doses that are required for achieving and maintaining the target base are also more gradual than in patient who is deemed low risk in the system. At the same time, the maximum allowable rate of propofol infusion is also reduced in these patients, and the maximum achievable target concentration of propofol is also reduced, keeping in mind the altered pharmacokinetics and pharmacodynamics of propofol, which I already told in the previous slide. And at the same time, the CLADS is having continuous hemodynamic as well as the BIS feedback from the vital signs monitor. So whenever the hemodynamics gets below a certain limit, which we can choose by ourselves also, so whenever that hemodynamics goes below that set limit, the propofol infusion stops by itself, and whenever that hemodynamic parameters are again within normal range, it automatically starts infusing the drug again, and the delay time is also really less, and the response time is only 10 seconds in this case. So we will share our experience with the most extreme patients we can think of, that is the heart transplant recipients who are having end-stage heart failure, going for heart transplant. So how our CLAD system performed in these cases. So I will go by case analysis. So the first case was a 14-year-old male with decompensated dilated cardiomyopathy with ASA4 and NYHA grade 4 with LV ejection fraction of only 12% with moderate to severe MR as well as TR. So let's see how CLADs performed in the pre-CPB period. So this is essentially the time graph of mean arterial pressure, heart rate, BIS as well as the propofol infusion rate of the patients. The gray line indicates the mean arterial pressure, the yellow line is the heart rate, the blue line is the BIS, and the orange line at the below is depicting the propofol infusion rate. So talking about the induction, the time taken for loss of consciousness was 75 seconds in this patient, and time taken for induction, now induction is defined in CLADs as 2 consecutive values within target range for the first time after starting the infusion. So the time taken for induction was 135 seconds and the dose needed for induction was only 0.58 milligram per kg of ideal body weight of the patient. Now you see this is the initial drop. This arrow indicates the initial drop of BIS at the time of induction. So from around 70 it came down to 50. So that is the induction point. So after achieving BIS, you can see that after coming into the target range, the BIS is maintained fairly well within our target range of 40 to 60. So this is our target range of 40 to 60, and you can see the BIS has been maintained fairly well within this time period, more than 90% of the time. Now this is the minimum blood pressure that we achieved during induction. So from the baseline of 90 it came down to around 65. So there was around 25% drop from the baseline. However, it did not go beyond that. So the 65 also is a reasonable blood pressure in this patient. So it did not go down to very dangerous levels. And this is the 25% line of the baseline. So you can see in most of the times the mean arterial pressure was maintained above the 25% less than that of the baseline. Now this is the lowest heart rate that we achieved during the induction, and after that it maintained fairly well above the less than 25% from the baseline. And some situations you can see there were some acute hemodynamic perturbations due to surgical manipulations, of course, during cannulation or during manipulation of the heart. So there were acute drops in the mean arterial pressure as well as the heart rate. Now you can see the response of the CLAD system lower, where sensing the hemodynamic instability, the propofol infusion rate has been promptly cut off, and as soon as the mean arterial pressure or the heart rate has gained its normal values or above the limit which we had set, the infusion had resumed automatically very fast, and the BIS has been maintained well within the target range. Now this is the performance after the patient came off the bypass. Here also we can see the BIS has been maintained fairly well within the target range, as well as there has been minimal perturbation throughout the course of heart rate and mean arterial pressure during the course of the surgery. Now coming to the second case, which is also a dilated cardiomyopathic patient with 23 years of age with NYHA 4 and ASA grading 4, again having ejection fraction of only 15% with moderate to severe MR. Here the loss of consciousness took 75 seconds, the time taken for induction was 105 seconds, and dose needed for induction was 0.42 milligram per kg. This was the induction point, and in this case, now there was we noticed some high wobble in this case, because at that time the CLAD system was not as compact as this. So there were some interface issues with the syringe pumps and with the vital signs monitors, which led to this fluctuation, but still you can see that BIS was maintained within 40 to 60 for a fair amount of time. And also the mean arterial pressure as well as the heart rate were also maintained quite similar throughout. Now this is the performance of the case in the post bypass period. Here also there was some ups and downs of the BIS, but on an average it was maintained quite well, and the mean arterial pressure and heart rate were also maintained in a similar manner. Without some fluctuations were there, obviously, because this was a patient with a very high severe pH and we had to use nitric oxide for this patient. So there were some hemodynamic perturbations that was related to the more than the anesthetic conditions. It was more related to the surgical conditions as well as the patient's function as well as RV dysfunction. But still the BIS was the CLAT system was able to maintain the anesthetic depth for fair amount of time. Coming to the third patient, again a 24-year-old patient with dilated cardiomyopathy with 14% ejection fraction with NYHA grade 4. Here the time taken for loss of consciousness was 68 seconds and time taken for induction was 215 seconds, and dose needed for induction was 0.82 milligram per kg. This was the induction point. After that you can see the BIS was maintained within target range for almost 90% of the time. This was the map of the induction, and this was the heart rate at induction. After that there was some fluctuations at that time also. You can see in the propofol infusion graph, whenever there was hemodynamic instability, the propofol infusion rate was cut off by the system promptly, and whenever the hemodynamics recovered, the drug infusion again started promptly, and so that did not allow the BIS to go either very low or very high, and it was maintained within the target range, and none of the patients had intraoperative awareness or recall. So this is the showing the incidences of hemodynamic fluctuations and the response of the system. So in conclusion, in even high risk patients with decompensated heart failure, CLADs resulted in smooth and safe induction of anesthesia and maintenance of adequate depth of anesthesia for a reasonable period of time without compromising hemodynamics too much. Thank you.